Meanwhile, let's hear, I think, from Dr. Shweta Chaurasia, who will be delivering the Prem Prakash, a very prestigious award, Prem Prakash Disha Award. Her talk is on surgical outcome of full tendon modified Nishida procedure in very large angle complex strabismus. So I think that needs a huge round of applause because it's a Prem Prakash Award and it's really prestigious. Congratulations, Dr. Shweta.
Are often useful in improving ductions past midline and at the same time correcting large angle primary position deviation in large angle concomitant squints. But recessing tight antagonists with full tendon transposition can bear the risk of anterior segment ischemia if done in the same sitting, and the procedure doesn't become safe even when spaced in time. Partial tendon transposition and modified Nishida are safer alternatives, but their efficacy remains low. As we know that modified Nishida no-split, no-tenotomy transposition procedure consists of only 1/3 of the muscle width transposition with mean correction of only 30 prism diopters. We described full tendon, no-split, no-tenotomy modified Nishida procedure in bilateral medial rectus aplasia with good surgical outcome. So the aim of our study was to evaluate the safety and efficacy of our previously described no-split, no-tenotomy, full tendon modified Nishida in correcting large angle deviation in various complex strabismus. The medical records of the patients were retrospectively reviewed. The patients of complex strabismus who underwent full tendon modified Nishida with follow-up of more than 6 months were included in the study. Records of complete orthoptic measurement was taken, deviation was measured by PBCT, and ductions were recorded. Pre-op deviation and post-op deviation were compared using Wilcoxon sign rank test. Corrections achieved by full tendon modified Nishida alone was calculated for every patient, and mean corrections for all types of concomitant squint, and median of vertical and horizontal full tendon transposition myopexy and for all types of concomitant squint were compared using Kruskal Valley with Bonferroni correction. This is a short surgical video. Traction sutures were passed and the limbal incisions were made temporally. The superior rectus, the muscle to be transposed, was isolated. The check ligaments were dissected. The superior rectus was marked 8 mm from the insertion, and non-observable suture full thickness was passed through the muscle. 14 mm was marked from the limbus, close to the border of the paralyzed superior border of the lateral rectus, and the sutures were passed. The same sutures were passed through the superior rectus again, and the muscle was mobilized towards the lateral side. Similar procedures were done on the inferior rectus. So the whole width of the muscle was secured, unlike in modified Nishida, in which only 1/3 of the muscle was taken. In our procedure, it was passed close to the border of the paralyzed muscle, whereas in modified Nishida, it was passed midway between the two muscles. So the operative records of 1,021 patients were reviewed, among which 22 patients were included in the study. Mean follow-up was 2.7 years. Among them, 6 patients were pediatric. Mean age was 24 years. There were 7 monoocular elevation deficit, 8 6 nerve palsy, 3 muscle slippage, 2 isotropic DRS, and 2 exotropic DRS. There was no anterior segment ischemia. Among the 7 patients of MAD, all were congenital cases. All had severe ptosis with Marcus jaw winking. Mean inferior rectus recession was 4.93. The pre-op hypotropia decreased from 65 to 4.29 prism diopter, which was statistically significant. Mean supraduction deficit was -4.29, which improved to -1.36. And mean correction achieved by this procedure superiorly was 52 prism diopters. Bell's improved post-operatively, following which ptosis surgery was done in all patients. These are the photographs of some other patients showing primary position correction and improvement in supraduction. There were 8 patients of 6 nerve palsy. All were acquired post-traumatic cases. Mean pre-op esotropia improved from 65 prism diopter to 2 prism diopter 6 monthly, which was statistically significant. Mean pre-op abduction deficit improved from -4.29 to -1.36, and mean correction achieved by this procedure was 41.75 prism diopters. These are the photographs of some other patients showing improvement in primary position and esotropy. There were 3 patients of muscles, lost muscle. Pre-op exotropia improved from 71 to 21 prism diopters. Mean pre-op adduction deficit improved from -4.67 to -2.7, which was statistically significant. And mean correction achieved on the medial side was 51.67 prism diopters. There were 2 patients of exotropic DRS with 60 and 65 prism diopter. They underwent LR periosteal fixation with modified full tendon modified Nishida on lateral side. Mean abduction limitation was -5, which improved to -2 and -2.5. And correction achieved was 25 and 30 prism diopter, respectively. There were 2 patients of esotropic DRS and 45 prism diopter. Mean abduction was -4. They underwent full tendon modified Nishida and MR recession. Abduction improved to -1 in each patient, and correction achieved was 30 and 25 prism diopters. So overall mean correction was 44 prism diopters. Vertical correction alone gave 53 prism diopters, and horizontal gave around 40 prism diopters. Overall p-value for full tendon modified Nishida was statistically significant, but applying Bonferroni correction for multiple comparison, the adjusted p-value for each group comparison was not statistically significant. So it's a safe and effective procedure in correction of large angle incompetence strabismus and improving ductions when done in combination with ipsilateral antagonist recession. Without tenotomy, this technique displaces the full thickness pulleys of the bellies and hence the muscle center in the direction of the transpose site, which is close to the border of the paralyzed muscle. Thank you.